Hi, everyone. Lisa White with IVF Manifesting a Miracle. And today you're going to get to hear Dr. Greene from Conceptions for a clinical conversation all about PCOS. Hi, Dr. Greene.
How are you doing?
I'm great. Everything going well for you?
Oh, fantastic. Thanks for asking.
Yeah. So with this being September 2021, we're going to be talking about PCOS for PCOS Awareness Month. And first, let's have you define what is PCOS.
Well, first of all, the thing that I think is important is why it's necessary to have a PCOS Awareness Month. It's kind of mind-blowing that literally this is considered the most common diagnosis of hormonal imbalance in reproductive age women, estimated to affect at least 1 in 10 women.
Wow.
And at least 3 times as many if you're looking at people that are having difficulty getting pregnant. So, if you're looking specifically at women that are trying to get pregnant, this represents somewhere between 20 and 30% of patients in that category. Wow. One of the sad truths to this is even though this affects more than 5 million women in the United States alone, it's also estimated that only about 50% of people that have PCOS are ever properly diagnosed. So this is literally the most common disorder, and yet it's also the most commonly missed disorder. And that's why it's so important to talk about PCOS awareness, because honestly, for a lot of women, if they're not taking an active role in trying to help determine whether or not this is a contributing factor, they've almost got a 50-50 chance it might be missed.
Oh my goodness. Yeah, it's so important. So Polycystic Ovarian Syndrome, the symptoms, maybe let's start with how would people even know that they might have this?
Yeah, well, first of all, let's start off with a basic definition.
Oh,
I love simple definitions, and I could boil this down to 2 words. It's a hormone imbalance. And I love that definition because it's both deliberately simple and yet exquisitely accurate. And the point is there's a lot of hormones that are kind of dynamically interacting with each other in anybody's physiology, but in women, the changes that go on in hormones, they vary day to day, they vary week to week, and certain hormones will vary in their blood levels within the same day. And so the point is that this is a hormone imbalance that specifically affects the ovaries, which is why it's called Polycystic Ovarian Syndrome, in ways that can influence pregnancy in several different ways. In some women, it's a reduced chance of getting pregnant. In others, it's actually a higher risk of miscarriage. So in other words, women that have PCOS, statistically, it's 3 to 5 times harder for them to conceive because they don't always release a mature egg. Some of them do, some of them don't. But when a woman with PCOS is pregnant, she's actually 3 times more likely to miscarry early in the pregnancy than someone that does not have PCOS.
3 times more likely?
3 times easily. And even more bothersome is if someone does get pregnant with PCOS and does not miscarry, she's about 4 times more likely to develop blood pressure problems like preeclampsia, as well as at a higher risk of developing gestational diabetes in the second half of pregnancy.
Oh my goodness.
So the bottom line is this is a hormone balance that changes. It changes at different times in a woman's life, but it also changes from when she's not pregnant to when she is pregnant, but it never really goes away. And that's why the awareness that someone has PCOS gives them the insight to actively manage the problem, to manage it in such a way that it becomes easier to manage symptoms when they don't want to get pregnant, to manage their condition as much as possible to help them get pregnant when they want to get pregnant, and at the same time taking steps to try to reduce the risk of miscarriage or complications during pregnancy when they are pregnant. But it takes awareness to actively manage PCOS.
Okay, so there's a few questions that came in, and there are different types of PCOS. I've heard sometimes 4, sometimes 5. Can you?
Yeah, and what you're getting at is in the past, there have been at least 4 major organizations that used to use different criteria to try to diagnose PCOS. Okay.
Mm-hmm.
Now, there was an attempt about 15, 17 years ago to try to unify, and it was called the Rotterdam criteria. And it focused on 3 key issues. Instead of looking at the symptoms, because the symptoms are highly variable for different women, trying to look at what we call signs, things that are more objectively measured than just symptoms.
The science, you're the science guy.
Exactly. And so they focused on 3 major criteria. One is whether or not women have what appear to be polycystic ovaries on ultrasound. So it takes an ultrasound to see if someone has polycystic ovaries. But if someone has polycystic ovaries and has nothing else, they don't have polycystic ovarian syndrome. So a second criteria that was looked at is if a woman has either irregular menstrual cycles or difficulty getting pregnant. Don't have to have both, but have to have one or the other.
Okay.
The third criteria that was looked at is if a woman has either elevated testosterone levels on blood test, or if she has clinical signs of elevated testosterone, like oily skin or excess hair growth. And the point is that being that women are of different genetic backgrounds, some people could have excessive hair growth with normal testosterone levels, and other people, basically will have very high testosterone levels, but will never develop those skin problems, because that's where genetics comes in. And so they focused on these 3 different criteria, and based on the, Rotterdam criteria, all someone needed to have was 2 of these 3 categories in order to make the diagnosis.
Okay.
And what they did is they tried to show with a Venn diagram with the 3 different criteria. If someone had these 2, they were in category 1. If they had these 2, they were category 2. If they had these 2, they were category 3. And if they had all 3, then they were the classic PCOS patient. And notice that what this was an attempt to do was to eliminate the symptoms as being the primary diagnostic criteria. Because for some people, what they consider symptoms, they consider, oh, this is normal. All the women in my family had the same thing, and it can make things very misleading. And it also didn't take into consideration genetics.
Okay.
Like a classic example, for instance, is Asian women with PCOS, just because of their genetics, don't get excessive hair growth. It doesn't matter how high their testosterone levels go.
Okay.
Whereas, for instance, Hispanic women or women from Northern Italy, they'll sometimes have excessive hair growth with very normal testosterone levels. And this is how genetics can play into the diagnosis and make it so that different women have different symptoms, even though they have the same underlying condition.
Okay. So step 1 is kind of an awareness. An
awareness, absolutely.
For testing. And if someone knows that they have PCOS, and they're maybe beginning fertility treatments, can you give some guidance as to what people can either expect or look for as they're beginning, say, IVF? Or are there more challenges that arise when someone has that diagnosis?
Well, again, one of the things that's really important is individualizing each person's situation, But, this gets to the point that, number one, a lot of times people say, why do I need an ultrasound? Well, without an ultrasound, you can't measure if someone has polycystic ovaries.
Yeah.
It's not something you could feel. It's not something that you can weigh. It's literally based on their appearance on ultrasound. Okay. So that's really one of the very important criteria. More recently, people have talked about revising the Rotterdam criteria because AMH levels also seem to play a very key role in trying to make this diagnosis. And some people are saying an AMH level that's above 4.5 should be considered a fourth diagnostic criteria. You know, and again, there's debate on that. It's not universally agreed upon. But when you go back to the original definition that I presented to you, is with PCOS being a hormone imbalance, one of the key hormones that's involved in this disorder is AMH. But that's not the key hormone for all women that have this. But some women could have very regular menstrual cycles, have no excess hair growth. But if they have polycystic ovaries and a very high AMH level, they have many of the risk factors and challenges of women that have the full-blown PCOS symptoms.
And risk factors, are you talking more medical risk factors?
Well, it's medical risk factors, but it's also reproductive. In other words, women that have PCOS are also at higher risk of developing type 2 diabetes. They're at a significantly higher risk of developing heart disease. They're also at a much higher risk of developing problems like weight gain or even just thyroid abnormalities. So in other words, this is a hormone imbalance that affects different parts of the body differently. And it affects women differently at different stages in their life. And, you know, one of the things that I always try to stress when I'm describing hormones to people, whether I'm talking to medical students or patients or to other doctors, people tend to think of hormones as being something very fixed in time. You know, we're used to getting a blood test and people look at a number on a page and they assume that that right there is what their hormone level is. But all that represents is what their hormone level is at the time when that blood draw was done. And hormone levels are constantly changing. And they're influencing one another as well. And so the important thing is I always tell people the simplest way to envision it is like different elements on a mobile. You know, if there's always a little bit of dynamic motion, but everything is staying in balance, you know, like if one hormone level goes up and something else goes down to compensate for that, then you maintain that balance. But basically PCOS is by definition a hormone imbalance, so the mobile is not being compensated. And the point of that, when you think about hormones as being very dynamic, your diet, your lifestyle, this influences, these are how your actions and your choices can influence also to a certain degree what's going on hormonally. You know, I'll give you an example. You know, someone that's eating all the wrong foods is going to have a higher insulin level, even if they don't have diabetes, than someone that's trying to eat a healthy diet. Now, insulin can make the ovaries overproduce testosterone. And if someone has an ovary that's oversensitive to producing testosterone anyway, it can make a bad situation worse.
Yeah, we'll probably have to do a part 2 with diet and all of that. so many things to cover. But so let's give people like a lifeline, like some hope. So if someone has this diagnosis, PCOS, you get aware that you have this condition, and then it depends on the severity, right? For certain individuals may need different types of surgery, right? What would you?
Well, I mean, again, severity, it depends how you diagnose severity. Sometimes severity translates into more severe symptoms. Sometimes it can translate into more significant challenges, more difficult challenge getting pregnant, or a more difficult challenge staying pregnant, you know? So again, it's again trying to individualize where someone's at any given stage in their life. But again, with them being actively involved in the decision making, they can guide their healthcare provider, say, these are my key goals over the next 6 to 12 months. What's the best way to manage that? Because I would manage it one way if someone is trying to become pregnant. I would manage it totally different if someone is trying to not get pregnant, but they want to just optimize their health and wellness, you know? And again, it's also important because this is a dynamic hormone imbalance. We talked about risk factors like heart disease and diabetes. It's also been shown that women that have PCOS have a higher risk of anxiety and depression as well. Now, whether the anxiety and depression is because of a lack of understanding and control of their symptoms or vice versa is not an easy thing to establish. But what we could do is we could try to actively manage all of their symptoms as much as possible. But you sometimes have to prioritize, is the main goal going to be to achieve a pregnancy, and what's the secondary and tertiary goal?
So for our audience,
in other words, exactly.
For
but
our
it's
audience,
individualizing things. And the only way you could individualize this is if each person that has PCOS is first properly diagnosed, and then two, secondarily involved in guiding the decisions as to what's going to be. Because like sometimes, for instance, we might say, you know what, if our primary goal is to become pregnant, then there are certain things that, might also, not be able to be managed quite as well, but we could still manage them to a certain degree.
Okay. Is there any kind of tip you can give for someone that is trying to get pregnant and has PCOS? Like what would be one little strategy people can do? Or, I know it's individualized, but is there anything you can say?
To be honest with you, one of the simplest things that's been shown, there's a couple. One is absolutely to try to have more of a plant-based diet. One of the things that's unfortunate is a lot of people, they talk about paleo, they talk about, no carbs. The reality is none of that has ever been shown to be healthy or sustainable, and none of it's ever been linked to higher pregnancy rates. Sometimes you could lose weight on those programs, but that's not really associated with a higher pregnancy rate or a lower miscarriage risk. The one thing that's consistently been shown across all platforms to optimize the chance of getting pregnant is to have a primarily plant-based diet. Okay. Someone doesn't have to be completely vegetarian, but ironically, carbohydrates that people obtain from plants, especially whole foods, are actually very healthy. Like, I'll give you an example. People have often thought that fruit would increase the risk of diabetes, and the research shows the exact opposite. Fresh fruit actually is associated with a lower risk of developing diabetes. But if someone is drinking a gallon of orange juice, that's not whole fruit, Right. That's basically, you're taking away a lot of the water because you're concentrating it, you're taking away a lot of the fiber, and you're making something that's healthy into something that's unhealthy. Okay. You see what I mean?
Yeah.
And so that's why a whole food plant-based diet has been shown to be really helpful. Another example that's not intuitive is increasing soy consumption. A lot of people think that soy has estrogen and that would be bad for PCOS patients. And yet interventional studies where women with PCOS are deliberately included increased amounts of soy in their diet consistently demonstrate higher pregnancy rates and lower miscarriage risk. And it's believed it's because this improves egg quality and increases the chances of ovulation. So plant-based estrogens are not the same as estrogens that are produced in the polycystic ovarian ovary. So plant-based diet is a great piece of advice. The second one that I know is right up your alley is stress management.
Right.
Keep in mind, stress by definition is a hormone imbalance. It's an excess in stress hormones. And the term stress was first coined by an endocrinologist in the 1930s named Dr. Selye. Okay. Now, keep in mind, those stress hormones are called glucocorticoids because they can cause an increase in glucose levels.
Yeah.
Okay. Now that increased glucose can affect insulin, which can then affect the ovary. So if you're able to naturally lower stress levels through counseling, through meditation, through yoga, slow, deep breathing,
Yeah.
By lowering glucocorticoid levels, you can actually help reduce a lot of PCOS symptoms and also boost pregnancy rates and lower miscarriage risks.
This is so good. No, thank you for going there with me and giving those real practical strategies for diet, for mindfulness. It's all interconnected, isn't it?
It is. It absolutely is. And the point is that, PCOS awareness is first and foremost about awareness, because with that awareness gives women the opportunity to, first of all, participate in their care. Here's what my primary goals are. Here's what my secondary goals are. And here's what my tertiary goals are. You focus on the primary and you manage as many of the others as you possibly can without compromising the primary. And the primary goal will shift at different times in a woman's life. And it gives them back the power to then actively participate and direct their own care.
I was just going to say that that's really empowering to help individuals to step into this, be an advocate for your care, get involved, be an active participant. And that's something that people can control, is stepping into that. Right. Just
exactly.
Yeah. Thank you. This was so good. I appreciate all this information. You're wonderful.
Oh, absolutely. And like you said, it's PCOS Awareness Month. So if we have some specific topics or subtopics that come up, I think that would be a great opportunity. But let's start the month with a greater awareness.
Yes. Thank you. And if anybody does have more questions they would like us to cover on this topic, please send them to myself or Dr. Greene. He's at enhancingfertility.com. I'm at ivfmanifestingamiracle.com. We have so many topics we've covered. This is another really good one. Thank you, Dr. Greene.
Have a happy day.
You too. Thanks, everybody. Bye-bye.